I mean, when I talk to a patient and I hear them say, I'm not sleeping, I'm depressed, I don't have a sex drive, I have anxiety, I have pain, just anything like that, instead of jumping to, okay, well, here's melatonin for your sleep, or here's, St. John's wort for depression, or here's some maca for your libido. I mean, things I'm instantly thinking about hormones. And that's why I test every patient. Even if they're in their 20s, I'm still going to be checking hormones because I want to see what their baseline looks like. But in some cases, hormones are needed even earlier than what they may think.
Yeah, and I agree with you on that one. I mean, especially in a society now where we have constant stress bombarding us, right? And stress sucks our vitality. It sucks all our hormones up. It really depletes your body of all just energy.
Hey guys, welcome back to the Dr. Lowe Show. We are talking about all things hormones. This is my favorite topic. I knew since 8th grade I wanted to be, I said I wanted to be an endocrinologist, but once I learned more about hormones, I said I wanted to be a naturopathic doctor with a focus in hormones. And it's just been the best. I love hormones. They control everything in our bodies, how we feel, the way we think, uh, the way we move, there's so many different things that hormones do. So I know this is something that we will all relate to because anyone listening has hormones. And over the years in practice, I have definitely evolved more in how I do hormone prescribing. If I think that hormone replacement therapy is the right fit for a patient, I have moved a lot more in this direction. So I wanted to share just this approach with you guys, and I knew that the best person I wanted to have on the show was Mai. So we're going to be diving all into physiological restoration and what this is and all the little nuances with that. So a little bit about my guest. Mai is a compounding pharmacist, and she's the director of sales marketing and clinical education at Harbor Compounding Pharmacy, which I love. Been working with them for a while now and just had a great experience. She's earned her doctorate of pharmacy from the University of Pacific Thomas J. Long School of Pharmacy and has over a decade of experience at Harbor. In her role, she works closely with physicians and patients. She's great at explaining things, and I will talk with her with patient cases and just kind of diving through all the nuances of each case because every patient is different. In 2020, she launched Harbor Academy. So she's personally trained over 100 healthcare providers on dosing and management strategies on HRT. And she recently spoke actually at the California Naturopathic Doctors Association, and that was very well received, just educating naturopathic doctors in California and on this modality. She has a strong passion for advancing women's health. She's contributed to the development of oxytocin formulations. So we'll talk about what the heck that is. And she works with the Women's Hormone Network, working to educate healthcare practitioners on all things PHRT. So with that said, let's dive in. Welcome to the show. It's so great to have you.
Thank you, Dr. Noel. I mean, if you invite me to talk about hormones, that's that's my jam, right?
Yeah.
So I love that we're talking about hormones. Like you said, it's low hanging fruit. So one of the things I was talking to several providers about this, and like what do we tackle first? You know, um, Diet, exercise, heavy metals, mold, hormones, and like everyone's like, hormones are the low hanging fruit.
Mhm.
And I'm like, what do you mean? She's like, if you're a menopausal woman, you're hormone deficient. You should most likely tackle that first because once you get that in, the reward is so, im- you know, impressive. It's going to
Mhm.
change your willpower. So it's going to motivate you. You're going to get so much energy that you're able to do all these other things that you want to do to improve and optimize your health.
Mhm.
Um, restructure your diet, go out and exercise. So yeah, hormones, low hanging fruit. That's so rewarding. It's the best return
100%.
on investment.
Yeah. I mean, when I talk to a patient and I hear them say, I'm not sleeping, I'm depressed, I don't have a sex drive, I have anxiety, I have pain, just anything like that, instead of jumping to, okay, well, here's melatonin for your sleep, or here's, St. John's wort for depression, or here's some maca for your libido. I mean, things I'm instantly thinking about hormones. And that's why I test every patient. Even if they're in their 20s, I'm still going to be checking hormones because I want to see what their baseline looks like. But in some cases, hormones are needed even earlier than what they may think.
Yeah, and I agree with you on that one. I mean, especially in a society now where we have constant stress bombarding us, right? And stress sucks our vitality. It sucks all our hormones up. It really depletes your body of all like just energy. And especially in young people too. Like yeah, I was just talking to a friend the other day. I'm like, if there were like 5 easy things I could tell someone to do to manage their health, it would be, eat less sugar, drink more water, sleep, right? Exercise. And I mean, I forgot how many I've listed off already. But then the last thing was like, I said stress reduction. But then I was just like, no, 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 scratch that. Stress management, right?
Right.
Because we don't want to reduce our stress. Stress is good. Challenges are good for the body, but
Mm-hmm.
we need to manage how we respond to it. And yeah, like everyone across every age group probably needs some hormone optimization, maybe some less than others. Like, premenopausal women may not need so much, but we still have some women in that population today that still needs optimization.
Mm-hmm.
So I get it.
Sure. I'm curious, just like a little bit of just personal background for you, you being, a pharmacist. Is this something that you initially were interested in, or did you move in this direction as you were working in the industry?
I just moved naturally, but now that you had said that you are interested in endocrinology, it's so funny because when I was in pharmacy school and I was learning about endocrinology, I'm like, oh my gosh, like I would love to be an endocrinologist. I just love how things are so connected, how like one hormone can affect so many parts of the body and how it has a negative or positive feedback effect on other hormones as well.
Mm-hmm.
Hormone receptor relationships, whatnot. Um, it's like engineering, and I have a very engineering kind of like mindset, you know?
Yeah.
Like I think of everything as algorithms. It's terrible to think of it that way, but like that's how I see patterns. That's how
Mhm.
I set up things in my head. You should see how I set up algorithms for like my team. They're
Yeah.
like, okay, mine, not another algorithm. I'm like, it's so easy to navigate.
They're so juicy.
Yes,
I
I
agree. My
know.
brain thinks like that too.
Yeah, and so, that's how, like, I think that my passion probably was seeded in learning about endocrinology first, and then as I got introduced to, hormones, especially specifically women's health, being a woman myself and, being a family of many women, right? Like, my mother was one out of, like, 8 sisters, and seeing,
Wow.
my mother and my aunts go through perimenopause and menopause, it made me think, like, different perspectives on, treatment for our perimenopause, menopause, and like how are we doing it today? What are the
Mhm.
different ways to do it and which way is the best way? Because
Yeah.
for me, seeing my mother go through it, as anyone would want, you'd want the best for your mother, right?
Mhm.
You want her to have the best, especially if you're in healthcare, you want her to have the best treatment. For
Mhm.
yourself, it's a little different because I'm willing to experiment. It's my body. I am held accountable for my own body. But for my mother, I have my aunts to respond to answer to. I have my siblings to answer to. So, but anything I do with my mother is it's judged at a much higher level. So
Mhm.
I choose what's best for my mother, and what I chose for her was Physiologic HRT.
Mhm.
Yeah.
So I'm curious, are her sisters doing it, or is there a difference between the ones that maybe are or aren't? How's that look?
So, I mean, my other aunts, some of them, like being Asian, this is a
Yeah.
very, I guess it's a topic you don't talk about, right? It's just an expectation that when you get older, you age and you lose your memory, you have aches and pains, you get wrinkles, and you just got to deal with it, right?
Yeah.
Especially with Asian cultures. And so my aunts, they don't really talk about it, and they're not on PHRT,
Mhm.
but, I'll say that, for my mother, I mean, she is 1 out of 8 sisters, but she's the oldest one, and she's the one that's just, like, the, most energetic. She
Yeah.
walks 4 miles a day, right? She still works a laborious job and,
Mhm.
just carrying 50 pounds a day of, like, anything, and she still can do it at the age of 65. And I was
Mhm.
just like she's like she's like, "Mai, like, the only reason I can do this is because of the hormones you gave me." Like, a
Mhm.
day, if I miss 1, 2, 3 days because I forgot to order it, she's like, "I feel terrible."
Yeah.
So
Right.
I get it. Yeah. Those
Yeah.
3 mothers.
Well, what people don't realize is that it's not like at some point your ovaries are just going to start making hormones again. So when patients ask me, Like, do I just do this for a little while and then I stop? It's like, well, it's not like your ovaries are all of a sudden, okay, I'm back on the job again. So it is something that, you're giving the body something that it had for decades and now it doesn't have anymore. So you truly are replacing it. And I can say for my mom also personally, she's taken hormones for a couple of decades now, probably 3 decades. She's 73. She just turned 74, and I think since her early 40s, because she did a surgical menopause with had a hysterectomy, and she doesn't have the same issues her friends have, libido issues or cholesterol imbalance, not to put her on blast too much, dryness, like stuff like that. She doesn't deal with that, and she has a good mood. Her skin looks awesome. She has this beautiful, luscious hair, and I'm just so happy that this has been something that she's been able to do. And her bones are very strong too. She doesn't have osteoporosis like a lot of her friends. Her bones look like she's in her 20s. So it's really an awesome thing. So I want to dive into like why this is something that women should be thinking about. Estrogen, unfortunately, even though the bad information that came out about it is from so long ago, so outdated with just flawed research. But there is still a fear about estrogen. It's like the cancer conversation is one of the first things patients bring up. Like, I don't think I should take this because I don't want to get cancer. So
Yeah.
can we just talk a little bit about estrogen and some of those fears around it and why this is something that we really do use, confidently?
Yeah. So, I mean, that's the Women's Health Initiative, right? And before the Women's Health Initiative, before that study was done, and that study was sponsored by the National Institutes of Health. I mean, before that study, there were already a slew of studies that supported the use of estrogens in the context of treating osteoporosis, cardiovascular disease, and then like even like preventing breast cancer. There were already a
Hmm.
slew of studies before that. The thing though is that all those studies were observational studies. They were all retrospective observational studies, meaning like they looked at women who used hormones already or women who did not use hormones, and then they assess like, oh, the women's on hormones, like what was their blood pressure, what was their lipid panel, what did their bones look like.
Hmm.
They didn't gather a group of women like and who were not on any hormones and then gave them, hey, I'm going to give you hormones, and the other half I'm not going to give you hormones, and now I'm going to study you from this point forward as
Hmm.
the randomized controlled trial. And that's what the Women's Health Initiative was. Well, so before the Women's Health Initiative, there were already a lot of positive support for estrogen. And
Hmm.
the reason why the Women's Health Initiative was conducted was because we wanted to prove that there was a positive support for estrogen using this gold standard of a randomized controlled trial, right? The
Hmm.
issue was that after the Women's Health Initiative, the statistics that were done were misconstrued, misunderstood by the media, right?
Hmm.
The term relative risk was overblown. And, you know, it's just like, I mean, to simplify it, it's just like saying like one group had one out of 1,000 out of 1,000 women, one person would have cancer. The other group out of 1,000 women, two people would have cancer. So they would say that in the other group, the risk of having cancer doubled.
Right.
Extreme, right?
Yeah.
I would freak out, but
Yeah.
then it's only one extra person. It's nothing. It's nothing. And so that's what happened. The media said, oh, if you use hormones, you use estrogens, you get like, a 40% increase in cancer. It's not
Hmm.
true. The relative risk, that statistic was misused. They say statistics is another form of lies. In essence, it is, right?
Yeah.
So this way it was misused. And so after the Women's Health Initiative, there was this fear of estrogen, right? That estrogen caused cancer. And from that fear, now we have, from that Women's Health Initiative, we have estrogen causing cancer, that fear. And then the other fear is like, I need to use the lowest doses,
Right.
right? Because estrogen causes cancer. I need to use the lowest doses to give me that quality of life, to help me sleep. So help me not burn up with hot flashes all day, just enough so I can survive being a woman, being a mother, being a wife, worker, whatever else it is, but without me getting cancer.
Right. Yeah.
Here we are. The Women's Health Initiative was finished around the early 2000s. 20 years later, we are still bought into the lowest effective dose approach.
Hmm.
And from that, so we have using the lowest doses, but then we're not thinking about what women what do we constitute of? We also have a brain, we also have breasts, we also have a heart, bones to protect. And the lowest effective dose doesn't do that. That's the crazy part. Like
Yeah.
now like guidelines come out and they say like, oh, you don't have to measure estradiol levels. You just need to give the lowest dose just to manage symptoms. But little do we
That's so
know,
wrong. Yeah.
yeah, this is where like I come in, and you probably see this all the time, like women coming in on the lowest effective dose and their estradiol levels are like 30
Yeah.
picograms per milliliter. And they feel fine. They don't
Hmm.
feel like themselves, but they feel fine. They can like they're surviving, right?
Yeah. Good
They're
enough.
gripping onto life with like just like, 10 fingers, right?
Yeah.
And and you're like, your estradiol is 30. 30 picograms per milliliter is not going to do anything for your brain. It's
Hmm.
definitely not doing anything for your bone, and it's not doing anything for your heart. Like they say that to get you to stop bone from resorbing, you need an estradiol level of 60 picograms per milliliter,
At
minimum
least. Yeah.
60. But to help you get to the point where you can actually build bone, your estradiol levels need to be at least 100 picograms per
Hmm.
milliliter. So here we are. How many millions of women do we have that are postmenopausal with levels less than 60?
Hmm.
And then we have this, I think is like more like an epidemic of osteopenia and osteoporosis in women in our country, right?
Yep. Yep.
Um, s- I'm not sure about you, but I see so many women with at 40, 50 with osteopenia already,
Yep.
right?
Totally. I've seen it even in their 20s for women who've been on birth control pills for a long
Exactly.
time. Yeah.
Yes. Yeah. So
Mhm.
that's what stemmed from that ugly study called the Women's Health Initiative,
Yeah. And was it
where
really estrogen? Was it really bioidentical? It wasn't, they weren't really looking at that.
I mean, they weren't looking at bioidentical estrogen. They used conjugated equine estrogen, which is a horse estrogen, equine, meaning horse, and they
Mhm.
used an oral estrogen, which wasn't beneficial at all.
Right.
Um, but I mean, even the horse estrogen, there were positive benefit when it came to breast protective effects.
Right.
Right? They showed that even horse estrogen had some protection for breasts. But the bottom line is look at what we have available today, right?
Mhm.
Why don't we just use bioidentical estradiol? And
Mhm.
why don't we just use transdermal estradiol versus oral estrogen versus equine estrogen? Right?
Mhm.
We have better options today. So why should we use like what was utilized in that study?
Yeah. What has the research looked like in current days for using bioidenticals? Like anything that you can share that is supportive of using bioidenticals and benefits of that?
Yeah, I mean, especially if there's one very important hormone that you should use bioidentical, it should be progesterone. One.
Mhm.
So the medroxyprogesterone acetate, the one that was used in the Women's Health Initiative, that one is extremely cardiotoxic, breast toxic. I mean, in that study, the breast cancer, I believe the breast cancer was attributed to the fact that women were using medroxyprogesterone acetate.
Yeah,
Because
I agree.
the women that did not use medroxyprogesterone acetate but used horse estrogen, equine estrogen, even they had breast protective effects. They had
Wow.
a reduction of breast cancer risk. But
Mhm.
once the other group that used medroxyprogesterone acetate, they had an increased risk of breast cancer, even though is a very small amount. The
Mhm.
addition of medroxyprogesterone acetate negated the breast cancer protective effects of the conjugated equine estrogen.
And
And
it's
so
so
that's a
opposite of what
snapshot.
people think. Like people
Yeah.
don't know that. Yeah.
So nowadays, like I say, I mean, medroxyprogesterone acetate, that's like cigarettes at a pharmacy. I wouldn't use it unless it's a last resort and used temporarily for 10 days for
Mhm.
heavy bleeding. That's it.
Right.
But like if you're using hormone replacement therapy for the sake of replacing your hormones on a uh, consistent basis, use progesterone because progesterone helps build bone.
Mhm.
Yeah, everyone always thinks estrogen helps build bone. It's actually estrogen helps slow down bone resorption, slow down the breakdown of bone. And progesterone comes in and builds that bone.
Mhm.
But if
Mhm.
you have too much bone breakdown, you can have, you're trying to build bone, but if you have too much bone breakdown at the same time, you're not going to have any bone building, right? So you
Right.
have optimal levels of both. You need to
Mm.
make sure bone breakdown is suppressed and then progesterone levels is optimized so that progesterone can build back that bone.
Mhm.
So,
Mhm.
um, definitely bioidentical progesterone If I had to choose between bioidentical progesterone versus hydroxyprogesterone acetate, or bioidentical estradiol versus conjugate equine estrogen, bioidentical progesterone first, right?
Agree. Yep.
Yeah.
Yep. I find that that is what drops first, typically, like in the 30s. I'll see that starts to get not so impressive on their labs. And then, periods become more uncomfortable, more insomnia, anxiety, cramps, maybe periods are too heavy, stuff like that, bringing in some progesterone initially oftentimes can be really helpful. I know for me, when I'm currently pregnant at the time of this recording, so at 44, I've never used estrogen personally, but I was using progesterone when I got pregnant and for my first trimester, and I really felt like that was super helpful for me. So it'll be interesting what happens once I have this baby, how my hormones change. So I will definitely be doing some testing and probably get on some HRT if that's needed. But yeah, let's dive into the specific effects of each of these hormones. So when I think of estrogen, I'm thinking of mood, I'm thinking of bones, I'm thinking of hair and skin and libido. And what are things you think of with estrogen? Anything beyond those effects?
Oh, estrogen, like reducing brain fog.
Yeah. Yeah.
Um, just it's so funny because estrogen and progesterone are opposites, and um, I see sometimes the mistake of patients being on too much progesterone compared to estrogen.
Right. Agree.
You see that too, right?
Yep.
And
Yep.
because there's like again, it stems from the fear
For
of
sure.
estrogen causing cancer. So they overdose patients on progesterone. Then guess
Hmm.
what happens? Patients get brain fog because progesterone, like, you're pregnant, probably feel it. This excess
Girl. Yes.
progesterone, the brain fog.
Yep. Prego brain is real.
Yeah, that's prego brain is from progesterone. So that's
Mhm.
one. Estradiol can definitely help with brain fog. But here's number two, the thing people don't know is that estrogen also helps you build stronger muscles. Testosterone helps you build muscles, but it doesn't help you gain strength. Like, you don't have strong muscles. You build muscle mass. But it's estrogen that brings energy to your muscles because it improves mitochondrial function in your muscles and
Mm.
helps you build stronger muscles. That's why, like, if you reason why I'm looking to this, I know this because, like, I lift pretty heavy weights, and I like to optimize my weightlifting, my personal records.
Love
And
it.
I like to hit my personal records during my follicular phase. When I have estrogen
Mhm.
only, when my estrogen is high, my testosterone is also high during follicular phase. And so estrogen, if you're going to be lifting heavy, you want to help recruit that muscle, set personal records. Do it in your follicular phase, along your ovulatory phase when you have your estrogen levels the highest. I mean, Dr. Stacey Sims also supports this as well.
Yeah.
And progesterone during your luteal phase, the later half of your cycle, is when you're kind of like your energy levels a little sucked up because that progesterone is kind of like a downer, right? It's a calmer,
Yeah.
it's a calming hormone, but calm also means a little bit of down as well.
Mhm. Mhm.
So estradiol definitely helping with brain, that progesterone doesn't, helping with muscle building that progesterone doesn't, and also estrogen also helps with skin. You
Yeah, big
this
time.
mother has amazing skin at this age with her hormones.
Yeah, right. I mean, she really has wrinkles and she's in her 70s. It's crazy.
Yeah, and
So, yeah.
I wish I had a picture of my mother at the age of 60. Her skin, like, people thought at this one, like, we would go to the grocery store, the people think we're sisters, and I'm
Oh my
like,
gosh. I bet she
she
loved hearing that.
yeah, she loves hearing it, and she's just like, "No, I have 4 kids." She's my daughter, and I'm like, "Thanks, mom."
That's
But, I
really
mean,
cool.
estrogen builds collagen in the skin, and
Mhm.
it builds natural moisturizing factors in the skin. Like, if you have estrogen, you don't need hyaluronic acid.
Mhm.
So a lot
Mhm.
of people don't know that if you have estrogen, you don't need hyaluronic acid because estrogen stimulates your skin to make its own hyaluronic acid and other natural moisturizing factors as well. Hyaluronic acid is not the only natural moisturizing factor in the skin. There are tons other, and estrogen stimulates all of them.
Wow.
Right, and hyaluronic acid isn't cheap, right?
Yeah,
Yeah,
right.
and it's kind of like it's hard to use as well. You have to be very, picky about which hyaluronic acid you use because hyaluronic acid is such a large molecule. If you put it on your skin,
Yeah, it sits
it
there.
can't absorb into the skin. But
Mhm.
estradiol can absorb into the skin, and it helps you make hyaluronic acid inside of your skin.
Mhm. That's super fascinating about estrogen activating those factors for your
Yeah.
skin. And joints too, I find, real common to feel like my joints are just kind of like these rusty hinges in my body now, when estrogen drops, and how much better just joint pain, like frozen shoulder, those kinds of symptoms just alleviate when you get your estrogen boosted.
Yeah, estrogen, like, it's a natural lubricant for the entire body, you
Mhm.
know, for
Including your vagina.
your vagina, right? Your skin. There are use of estrogen eye drops for dry
Mhm.
eyes, right? For your joints, it's just everything.
Mhm.
So
That's
that's why we like hormones, low hanging fruit. You don't
Yep.
have to prescribe 4 different things for 4 different conditions. Prescribe estrogen, and you've tackled so many.
Right, totally. With progesterone, I think of mood, I think about sleep, I think about, if you have low progesterone, you're gonna feel more anxious and have more insomnia.
Mm.
What are some more things you think of with progesterone?
Progesterone, I mean, the biggest benefit for progesterone is building bone.
Yeah.
That's how I see it. On
Mhm.
the other hand, like, progesterone, you have to have a good balance. Too little of it, like you said, you're gonna have heavy periods, you have cramp,
Right.
right? And then too much of it, you can have the bloating, weight gain, and if you have too much of progesterone, you could also have hair loss.
Yeah.
People think I am glad that you mentioned it earlier, like estrogen, you think of estrogen in hair.
Mhm.
And people think like, "Oh, during, pregnancy, you have so much hair," right? Because it's that, progesterone. Like, no,
Mhm.
it's also because of that estrogen that's also flowing in pregnancy. And the
Mhm.
reason why I bring that up is because, like I said, I've seen so many patients who overdose on progesterone compared to
Mhm.
estrogen, and I see the hair loss. And I'm very particular about hair for my women,
Yeah.
as hair is a very sensitive matter for me, because I, at one point in time, I lost a lot of my hair, right?
Mhm.
And I was just like, to recover, to grow that back takes years.
Yeah.
And
Was that
so
after having kids? I know you have 4 kids.
exactly, right? So having 4 kids, and then having to, see all that hair loss after pregnancy, and then regrowing that hair was
Yeah.
a big, huge challenge. And so
Mhm.
for my women who are, I'm giving hormones for, I'm very careful to make sure we don't overtip the hormonal imbalance, right? Don't give too much progesterone or testosterone, because I want to conserve their hair. Just take it
Yeah.
slowly. But I'm more
Yeah.
aggressive with estrogen dosing
Mhm.
because
Totally.
estrogen is good for hair.
Yeah, exactly. Making sure that balance is there. You are a big proponent of oxytocin. Can we touch on that real quick? What's oxytocin? How can a woman work on that?
Yeah. So oxytocin is, everyone always thinks of the love hormone, right? But it's not like love in like, um romantic love. Still call it the bonding hormone. And when you bond with someone, when you connect with someone, it also reduces anxiety. So oxytocin, when we originally, at Harvard Compounding Pharmacy, when we created oxytocin sublingual formulation, like the sublingual tablet, we were thinking of, we saw all these studies that supported its use in libido and boosting libido of women. So we had, like, a few, like several women utilize it, and we asked them for their feedback, like, how do you like it? And they're like, well, it it reduced my anxiety. If I
Mm.
use it every day, it reduced my anxiety, and because it reduced my anxiety, I can connect with my husband more. I can see him in a rosier light. When he's chewing, he's not so annoying to me.
I don't
Right?
want
And I
to
was
have
like,
him. Yeah.
and when, for women, in order for us to boost our libido, the dishes needs to be done, the house needs to be cleaned up, the children are fed, and then, and then if we feel, you just look so much better at that time, and then, things happen in the bedroom. Men are a lot easier. Men can just pop a Viagra and call it a day. Women, we need to have a mental, preparation for it. And that's what oxytocin does. It helps alleviate anxiety. It helps you see that other person in rosier light, emotionally connect with them, so that when that time comes, you can, when, sexy nights happen, you can really, get into it mentally. Because
Mhm.
for women, our libido is not affected by just by genital arousal. Our libido is also affected by are we open to it mentally? Do we have
Right.
desire mentally? So oxytocin does that for women, and the dose I'd recommend is like oxytocin 50 units sublingually a day.
Mhm.
But the studied dose is an intranasal preparation. 20 units a day or twice a day works perfectly well. And oxytocin is also being used for migraines as well.
Mm.
Yeah, I know. So menstrual migraines. So where does oxytocin come from? Oxytocin comes from actually estradiol. It stimulates the production of oxytocin.
Mm.
So if you have enough estrogen in your system, you should have enough oxytocin,
Mm-hmm.
right? So how do they come up with the idea of oxytocin treating menstrual migraines? It's because when your estradiol levels drop, your oxytocin levels drop as well. And when your
Mm-hmm.
oxytocin levels drop, that's when the migraine happens.
Mm.
Because how does the migraine happen? The trigeminal ganglion neuron that's like running along right here, oxytocin blocks it from being triggered.
Mm.
That's the that's the neuron that causes that's the nerve that causes migraines. So oxytocin blocks it. So if
Mm.
you have your patient has menstrual migraines, the best way to treat it is with estrogen, right?
Mm-hmm.
But if they can't use estrogen, I would use intranasal oxytocin. 30
Mm.
units, 2 to 3 times a day should do the trick. There's
Interesting.
actually a pharmaceutical company that's actually trying to take it to market with the FDA right now.
Oh, wow.
Yeah, so we're trying to capitalize on it first
Yeah.
before they take it to market, because once they take it to market, it's probably gonna be like $500 to $1,000 like any other migraine medication.
And really, can they patent a hormone? They probably would have to change its structure in order to patent it, I would think, right?
They can patent it as long
Yeah.
as it is a unique method of delivery. So that's why the Vivell patch was patented. They didn't patch estradiol itself. They patented estradiol in a patch.
Mm-hmm. I see.
Yeah.
Interesting. What about for women listening that are thinking, well, I think my migraines may be like estrogen dominant, or maybe a practitioner has said that. Like, how does that can be confusing?
Yeah, I mean, some migraines can be caused by too much estrogen coming in at once as
Uh-huh.
well. But
Okay.
I've seen that pretty rarely, very rarely,
Yeah.
especially with women who are just like probably giving estradiol injections or giving a whole bunch of estradiol all at once.
Mm-hmm.
Most of the time, I see menstrual migraines with estradiol levels falling or with progesterone levels being too high, because the
Mm-hmm.
progesterone then blocks the effects of estrogen, right?
Right. That's why it's so important to do the testing. I know we're both fans of, serum testing and Dutch testing, looking in the urine and seeing how you're breaking it down. Because
Yeah.
two women are the same and how they balance their own hormones.
No, not at all, and that's why it's a personalized approach.
Yeah.
Just earlier today, I came across a study that a friend sent, and it was talking about how, women in the UK, everyone, they don't advocate for measuring levels, and so they expect everyone just to be on this one particular dose, like an estradiol zero point zero 0.05 milligram per day patch. So this study, they analyzed the serum levels in all these hundreds of women. They found that it can range from like 15 picograms per milliliter of estradiol all the way up to like 100 picograms per milliliter off of one
Wow.
patch.
Wow.
So if you were told that the patch was supposed to get everyone to 50 picograms per milliliter, the 0.05 milligram per day patch gets you to 50 picograms per milliliter, you would think that your patient got to therapeutic levels with estradiol. But
Mm-hmm.
she's only on 15. She only has 15 picograms per milliliter. So that's why it's
Right.
important to measure, right? And it's important to appreciate that everyone's absorption is different and
Yep.
everyone's metabolism is different. And the
Mm-hmm.
analogy I have is like, look, if you go shop at Victoria's Secret, there's like 40 different bra sizes for women.
Right.
More than that. I looked at it and I was just like, there's like, our that girth size and like cup
Yep.
size, multiply that, looks like at least 40 to 60 different sizes. And I'm like, it's very inclusive. But we look at our
Totally.
hormones, like look at our estradiol patches, there's like 5 different strengths, and everyone should only be on like 1 or 2 strengths. That's it. Like,
Right.
that's not inclusion.
Yeah,
We
it just makes no
It
sense.
makes no
It's
sense.
like you can have a woman who's real lean and another woman who's obese, and their absorption is going to be different. And
Yeah.
then one may have like an MTHFR mutation or COMT or whatever. They may break it down totally differently. So that's crazy. That doesn't make any sense. Yeah. So let's talk a little bit about the effects of these hormones on maybe other like preventative reasons to be on it. So like brain decline, cognitive health. I love brain health. We treat a lot of, anxiety, depression, but also just preventing things like dementia, Alzheimer's, the brain needs hormones. So tell us
Yeah.
about.
And so that's very interesting you bring that up because, have you read Dale Bredesen's book, The End of
Yeah.
Alzheimer's?
Yeah.
So, I mean, that book, I think every woman should read that book, or every woman who has a history of Alzheimer's should read that book.
Mm-hmm.
I've made it like, one of my Bibles specifically because, I have one of those ApoE4 genes.
So do I. Yeah.
Yeah. And so I've done everything I can. I follow that book almost to the T,
Mm-hmm.
right? And especially like my father being estranged from my father, I don't know his health history. I don't know what
Mm-hmm.
he what his what I'm carrying genetically. And so in that book, they actually seek an estradiol level of 100 picograms per milliliter.
Mm.
Dale Bredesen actually pushes that, but
That's
not everyone
great.
follows it, right?
Yeah.
So that's
Right.
number one. And number two, it's a great study that just came out showing like estrogen receptor uh, production in brains of premenopausal women versus postmenopausal women.
Mm.
And so what they found was that in premenopausal women, estrogen receptors in the brain are much lower than postmenopausal women. And I was thinking like that doesn't make sense. Like we always thought that in postmenopause, because we have low estrogen levels, the rest of the body will have very low estrogen receptors. And
Mm-hmm.
that generally is true, except for the brain. The brain has compensated that when it hits menopause, it needs as much estrogen as it can. So it overproduces estrogen receptors in the brain so that any little estrogen that's produced, it absorbs it right away.
It's just
Help with
starving.
the
Like, yeah.
to help with the help prevent cognitive decline, help with cognition. So the rule is now they look at it versus premenopausal women have lower estrogen receptors in the brain, right? Because they have enough estrogen in the system. They don't need that much production. So you need to have enough estrogen in order to reduce estrogen receptors in the brain to help with cognitive decline. And that level is around like 80 to 100 picograms per milliliter of estradiol.
Mm-hmm.
And so when people say hormones like don't work for me, they don't help with my brain fog, I'm always asking like, well, what level did you get for your estradiol? That's
Right.
very telling.
Yeah.
Right? If you're at 30 picograms per milliliter, it's not doing anything for you other than helping with your hot flashes.
Right.
And
Exactly.
and
You
here's
feel
another rule.
okay enough, but it's not
Yeah,
helping
okay
with
enough.
the
Yeah.
level.
And here's another rule. Like people think it's okay to have one hot flash a day or one hot flash a week. It's not.
Mm-hmm.
Like
Yeah.
hot flashes are really traumatic to the brain. You're like frying your brain every time.
Mm.
So the bottom line is that if you're on estrogen replacement therapy, if you're on hormone replacement therapy, you should not have a hot flash ever.
That's a really
Right?
great rule to follow. Yeah,
Yeah.
completely. Super, super cool. Let's talk about the difference between static dosing and physiologic HRT because it is completely different. So, when someone is on the physiologic HRT, like what does that look like? Or is it different? I mean, I know this because we work together on patients, but is this a different dose throughout the month? Talk about the fact that they're still gonna have a period that sometimes can be
Yeah.
a hard pill to swallow for a lot of ladies. Yeah, just kind of give us like some of the basics about it and how we even know that a person's doing the right doses too.
Yeah. So basically, what is physiologic HRT? Physiologic HRT is a method of giving hormones back to a woman that mimics the estradiol and progesterone levels that are naturally released throughout a menstrual cycle.
Hmm.
So a woman's hormone software, her estrogen and progesterone are produced, her optimal software is produced in the menstrual cycle. Because think about it, for women, we are healthiest during our reproductive lives, right? During the reproductive phase, when we're between the ages of 20 to 50 years old, I mean, more like 15 to 45, three
Hmm.
decades of having estradiol levels and then progesterone levels, estradiol levels and then progesterone, that cycle, right?
Hmm.
And if you look at that cycle, not every woman knows this. I feel like we need to be better with our teaching our teenagers about our own menstrual cycle.
Yeah.
Cycle, we have rising levels of estradiol that drops, and then progesterone rises, and then it drops. And when that happens, you get your menses. That's how you get your menses every month because of that. And so we are trying to emulate that with physiologic HRT. We're trying to bring that back for menopausal and perimenopausal women with physiologic HRT versus the low dose HRT approach, what you call static. I call like low dose HRT now because it's
Hmm.
just easier to understand. The low dose
Right.
HRT approach is actually a made up approach. Came from like there's no like um template where it came from. We just came up with the idea of like, hey, let's just give women like little doses of hormones just to help get rid of their hot flashes. That's it. So
Mm-hmm.
low dose HRT is just same dose every day. A little bit of estradiol, a little bit of progesterone every day. But you think about hormones like this. You think about hormone like melatonin, like insulin, right? If you have someone that can no longer make insulin, do you go up to them? Do you say, hey, let's just give you just low doses of insulin every day?
Mm-hmm.
No,
No,
you don't.
never happens
You
naturally.
follow like, hey, this is how insulin is released,
Mm-hmm.
optimally released. It's released before every meal or during a meal. 3 spikes throughout the day. Let's mimic that. We do that with insulin.
Mm-hmm.
If someone's melatonin levels have crashed, we don't give like, hey, say, let's give you a little bit of melatonin every morning. No, we see and we look at the melatonin production is at night and we dose it at nighttime only. So how come we didn't do that with estrogen and progesterone?
Yeah, right.
It's kind of
Sounds
nuts, right? It's probably because men are probably like, I mean, society, I mean, you think about it, a lot of medicine is focused on males. It's not focused on
hmm
women. Nowadays
Right.
it's changing. But the men and, a lot of clinics and practice and just operationally, it's kind of hard to be like, oh, which cycle day of your cycle is this? Like, let's make it this. Let's like titrate your dose throughout the 28 days. It's too hard for that. It's too hard for
Yeah,
that when your insurance only pays for you to go see your doctor once a year. So that's why
right.
I came up with the approach of let's just give the lowest dose once a day, call it a day. We'll see you next year.
Yeah, good enough.
Yeah, good enough. So physiologic HRT resurrects that cycle. But when we resurrect that cycle again in a menopausal patient, the thing though is that if we resurrect that cycle correctly, we should have a period or a menses at the end of the 28-day cycle. Because
hmm
if that happens in a premenopausal patient, in a reproductive patient, it needs to happen in a menopausal patient too. Because if it doesn't happen, if you don't get menses at the end of the cycle, it means that there is not enough estrogen and progesterone to build that lining, to build that uterine lining. And
hmm
so you think about this way, the uterus responds to the hormones, right? It builds a lining. But how about the rest of the body? You don't see it, but the bones are also rebuilding. The brain is also rebuilding. The breasts are also rebuilding, right? And if
Yep.
you don't get building in the uterine lining, you're probably not getting any um recomposition in the brain, the breast as well.
Right. Makes
So that's
sense.
why we
I
need to
mean,
have a
if you're
menses
that,
at the end of the
yeah, if
cycle.
you're the healthiest when you're having a period back in the day, then you're going to want to mimic that. Otherwise, you haven't truly mimicked that. So it just,
Yeah. Exactly. It's kind of like the analogy I have is like a garden with an apple tree, oranges, cherries, whatnot. If you're watering the entire garden, but now you don't care for apples anymore. If you're watering the entire garden, but now the apples are no longer growing, that
yeah.
means you're not watering enough, right?
hmm
So the apples is like your uterus. But let's say you're watering the entire garden and now you're growing apples, but the apples you're grabbing it, you're harvesting it, but you're throwing it away because you don't need it. That's your uterus, that's your period. That
hmm
means you're watering the entire garden enough.
Yeah.
So you can't the apple tree is like your monitor. Are you
Mhm.
gathering it and throwing it away? Versus like the orange tree and whatnot, the orange tree and the cherries, it's like your bones and your breasts and your cardiovascular system. There's not a waste that you see. The
Mhm.
endometrial tissue, the uterus, is the only organ that produces this waste that you can see as a sign that there's regeneration
Right. Makes sense. And the only way you won't get that is if you've had a hysterectomy.
or an ablation, an endometrial
Mhm.
ablation. Yeah.
Right. Yeah.
So that's why physiologic HRT is really powerful in that it brings back optimal doses of estradiol,
Mhm.
optimal doses of progesterone for you to build back your bones, build back, build brain, um, new neurons, new myelin sheaths for your brain, new breast cells, right? Your
Mhm.
breast cells never stay the same. They're constantly cycling. That's how
Mhm.
you prevent breast cancer. You need to cycle those breast cells. You just can't have old breast cells stay there and grow, right?
Yeah.
You gotta
And
constantly push them into apoptosis, push them to cell death, get rid of them, get ready for a new set.
yep, totally. Remodeling of tissues even beyond the bones. So for women going, okay, well, hell no, because I had the worst periods of all time, that doesn't mean that things were balanced back in the day, even though they were having
Correct.
a period. So it should not look like that when you're having
No.
the cycles with the physiologic HRT.
Yeah, I think that's a lot, the one of the biggest oppositions of physiologic HRT. Like, I'm getting my a period back. I don't want a period.
Yeah, that was
But
hell. Mhm.
yeah, but think it's a small sacrifice, I say, for 3 days of an inconvenience of having a period. But when you have 28 days, 365 days a year of optimal health versus low dose HRT method, you may not have a period, but you're just giving the lowest doses just to manage your hot flashes. You're not building back your bone, you're not getting a libido, you're not building back your brain, you're not protecting your breasts entirely. And
Mhm.
one of the biggest the feedback that I get that differs the most when you compare physiologic HRT to low dose HRT is my libido is back. Like
Right.
my husband's really happy. And I'm
Mhm.
like, th- and then I'll ask them, did you feel that way on low dose HRT on the
Right.
other? And they're like,
It's super
no,
rare that I see an increase in libido on low dose.
no.
Almost
And with
never.
physiologic HRT, like you're getting full penetration of that estradiol because it's such a much higher level than low dose HRT. You're getting penetration of the estradiol into the vaginal tissues as well. So you don't
Yep.
need separate estrogen vaginal cream for vaginal dryness because
Mhm.
you're replenishing estrogen everywhere.
Yeah. I've even had patients say my sex drive is better now than it was even in my 20s because maybe their hormones weren't even optimal then, right?
Yeah. And that painful bleed or painful menstruation that people have in their 20s and 30s, I get it because I was there too.
Mhm.
I tell everyone I'm at my healthiest now versus when I was 20 or 30
Mhm.
because
Yep.
of, knowledge, education, experience, but also being able to manage stress, you know, versus
Mhm.
20s and 30s. We are stressing out all the time. We're probably not eating at our healthiest, right? And we're probably drinking and partying a little bit too much every weekend. That's like me. So
Right.
the pay it's payback time when your period comes,
Yeah, exactly. No, that's a good point. So
right?
so with being on the physiologic HRT, the way that we know that someone's having the right doses is that you're having a cycle, it's heavy enough but not too heavy, and you're feeling good throughout the month, like your mood and you don't have aches and pains and brain function and all that stuff. So, how you're feeling throughout the month, how your periods actually feel, what your levels look like in your labs. So, that's going to be another way that we know. And there's targeted ranges, right? So, we're testing it a couple times throughout the month. It's not just once like you might do with the low dose. And with low dose HRT, you can pretty much check whenever because you're on
Yeah,
the same dose, right? But with
yeah,
the physiologic, it's mimicking the cycle. So typically day 12 and day 21, right? It's what's
yeah,
recommended. And we want to see that there's a targeted level that's reached. And then we make adjustments from there. And the only way we wouldn't use the period as a gauge is if, like you said, have an ablation or if you've had a hysterectomy. But it's very targeted, which I really love. It's not just like, okay, how are you feeling? Yes, we use that as a tool, but it's very much based on the data on with an individual.
correct. And
Mhm.
here's the thing, like one thing I like about physiologic HRT is you can adjust the dose as much as you need,
Mhm.
without any restrictions.
Mhm.
So, for example, with low dose HRT, if you don't want to have a period, if your patient doesn't want to have a period, there's only so much estrogen you can give. So
Yeah,
let's
because
say in low
eventually
dose
they will.
HRT, she's
Mhm.
like, doc, I'm feeling better, but my hot flashes aren't gone yet. I like to have it totally eliminated. You bump up the estrogen dose. But then she goes, but then I have vaginal bleeding now, I have spotting now. Then you're like, well, I have to lower the dose of estrogen now. You can't have your
Right.
cake and eat it too, right?
Totally.
But with physiologic HRT, you can take up the dose as high as you need without having that restriction of vaginal bleeding because we know we're going to have vaginal bleeding on day 28.
Mm.
It just needs to be a controlled and timed vaginal bleeding. So
Mhm.
this is why like our women in physiologic HRT, they'll never have a single hot flash. They'll never have vaginal dryness. They should have full cognition back, right?
Mhm.
And they're just living the best life
Yeah.
physiologic HRT. But
Mhm.
the
That's what I
only
see too.
only negative is that period.
Yeah,
So,
exactly.
yeah,
But it's
deal
an
with it.
inconvenience. You're not suffering, you're just inconvenienced because
Yes,
it's
inconvenience
usually a
by it.
breeze. It shouldn't be an uncomfortable thing. It just happens. It's just you bleed and then you don't. Um, So awesome. I love this stuff. I love it so much. It's like I kind of can't even wait to go on it myself once that time comes for me.
I
Um,
know. I would suggest, like, if women who are, if any women who are listening right now and they are premenopausal or perimenopausal and just want to check out what their cycle looks like, I
mhm,
highly recommend using a cycle mapping device, kind of like the Mirror app or
mhm.
the Anido app. Have you heard of those?
Yep, yep.
Yeah, just to see where you are in your journey. And if you find that this is something that you're interested in, at least you have those patterns available for you to present to your doctors, present to you, present to whoever they're seeing that they're like, I noticed that there's some irregularity in my menstrual cycles,
Mhm.
or I'm ready to start because look at where I am right now.
Yeah.
So I think that gives you more visibility, give you more insight in regards to your hormonal patterns versus like going in blind in your first appointment and not knowing where you are.
Mhm.
Because if you're perimenopausal right now, your cycle's all over the place.
Right.
Well, how do you time it? So like
Mhm.
mapping it out beforehand is actually a good idea. And for
Mhm.
patients who are premenopausal, who are like feeling great right now, I would say map out your cycle so that when you hit menopause later on in life, you know what your highest estrogen was, what your highest progesterone levels was, so you can emulate that
Mhm.
if you're
Right.
using physiologic HRT later on.
Do you think there's anyone who's not a candidate for it, in your opinion?
Oh yeah, I mean, they're all relative contraindications, but
Right.
if we can't follow directions or
Yeah.
stick to the regimen, that's a no-no because the
Yeah.
doses change every 1 to 2 days.
Mhm.
You've got a card, right? A dosing card and for estradiol and progesterone separately, and you have to know which dose you're applying every day. So
Yeah.
not so easy as like, oh, today's like, one capsule a day. No, every day it changes.
Mhm.
Two, contraindication, another relative contraindication is fibroids. If you
Mhm.
have a medium to large fibroid that responds to hormones and it worsens with hormones, probably
Mhm.
can't use physiologic HRT. It won't always, it may enlarge the fibroid and exacerbate it. So you have
Mhm.
to consider getting it ablated or excised.
Mhm.
And then if you have a hormone receptor positive breast cancer, an active one or history of it, you can use HRT, but probably need clearance from your oncologist.
Right.
And then, I guess the other thing is like liver disease because estrogens are cleared out by the liver. If you have any severe liver disease, which
Yeah.
I don't think any of us, our patient population, I don't think anyone in our patient population really applies. But
Mhm.
if you have like liver disease, like liver cirrhosis, probably may not be able to use estradiol with
Mhm.
physiologic HRT because the doses are too high that your liver can't clear it out. You need to
Yeah.
clear out the estrogen appropriately.
Yeah, or if you have, like, a newborn or young kids,
Oh, yeah,
right?
that too. Yeah.
Transfer, they might get exposure to the hormones because it's
Hormone transference, correct.
creams. Yeah.
Yeah. So,
Okay.
like, in the meantime, if you're handling newborns or infants or co-sleeping with, young ones, I recommend for now just the estrogen patch and oral progesterone
Mhm.
until they graduate from your bed and then
Yeah.
go to physiologic HRT.
Perfect. Super cool. I love this. I could talk about this all day, but we have, other things we gotta move on to. So any, parting words, any final thoughts you wanna leave with our listeners?
Yeah, and, physiologic HRT is not the right tool for everyone, right? We gotta be able to look at everyone and be able to meet them halfway. So what I always say is like, look, if you're considering hormone replacement therapy, the literature out there says you have to start it within 10 years postmenopause, even better within 5 years postmenopause to really fully reap the benefit of estrogen on the cardiovascular system. Because once estrogen is gone, that arteriosclerosis, that plaque that's being laid down in your blood vessels is just ramping up super fast. So you want to stop that ahead of time because once it's settled in, you can't reverse it. So
Yeah.
I would say for people who are thinking about hormones but have not, they're still thinking about it, like don't wait too long. Like make a decision soon and be aware of like uh, the possible consequences of delaying it because once
Right.
you pass 5 to 10 years you're not going to have that cardiovascular protection, so
Mhm.
consider it, talk to friends, talk to you, talk to pharmacies. We're here for patients too. And
Yeah.
there's so much support out there, right? This is the time to do it.
Yeah, exactly. And let's say you're listening and you're in your 60s or 70s, there definitely can still be some benefits for you.
Oh
It may
yeah.
not include the full benefits, like you said, with the cardiovascular health, but other benefits that you can still get, right?
Yeah. I mean, they say that the motto is the day you don't need estrogen is the day you're, 6 feet under. So
Right.
every day you need estrogen.
Yeah.
If not for your cardiovascular protection, for your brain, for your breast, for your bone, we
Mhm.
still have that going going to the end. So we need estrogen every day of our lives.
Yeah. Amen, girl. I can tell you that right now. And I'm excited to see how I'm excited, but I'm also a little nervous of how things are going to be after having this baby, but I know that I have tools. So, and I'm glad I have the knowledge, to be able to help for whatever's needed. So I will be calling you for sure.
Well, I know our patients are very thankful to have you, Dr. Noel. There's not a lot of physiologic HRT providers out there, and so
Yeah.
we're very thankful that you have embraced it and you're supporting it and offering it to your patients.
Yeah, exactly. So anyone listening, if you are interested in this, give us a ring. We're happy to do an assessment and see if this is the right fit for you and, just help get things back into balance. So, and you can feel like don't accept not feeling like yourself anymore. So it's not okay. Like life is long. I know people say life is short, but I truly think life is long and it's not fun if your hormones aren't balanced. So don't accept not feeling good. Let's get you feeling
Agreed.
better. Give us a ring. We'll put the link in the show notes if you want to follow more Dr. Mai's work. And thanks for being with us today. Appreciate your contribution and working so hard to help so many women
Thank
and
you so much as well. All right.
all right. Bye.
You have a good one.